Good morning, all. A very warm welcome to 18th Annual National Conference of Indian Association of Biological Psychiatry. Theme of the conference is Biological Psychiatry in Practice, Population and Policy. It is organized at Pune and supported by Pune Psychiatrist Association and Department of Psychiatry, Bharati Vidyapit Medical College, Pune. So it's day 2 of the conference. We are starting with poster presentation. There are total 14 posters for presentation. And today's esteemed chairs are Dr. Kamal Kalita and Dr. Swati Joshi. I welcome both of them on dais. Dr. Kamal Kalita is a senior psychiatrist from Assam, a psychiatrist with experience of teaching MD psychiatry student, MPhil student and PhD student of clinical psychology, psychiatric social workers and psychiatric nursing with special interest in young people, substance abuse, depression and psychotic spectrum disorder, along with gender and intimacy related problems. And Dr. Swati Joshi is an eminent psychiatrist from Pune. She has special interest in addiction and geriatric psychiatry. She has experience of 23 years of practice in this field. Dr. Swati Joshi practiced at Sneha Psychiatric Clinic at Kothurud and Kothurud, Pune. She is a member of Indian Medical Association, Pune Psychiatrist Association, Indian Psychiatric Society, and Indian Association of Private Psychiatrists. So I welcome both of them. Welcome on dais.
Thank you. Good morning.
Thank you, Nikhil. Dr. Kamal, you can start.
Yes. Good morning, all the participants. So thanks for the good presentation, what we call introduction. So at first, the rules is what we call displayed over here. Its total time is 5 minutes. 3 minutes for presentation and 2 minutes for discussion. And the order might be told by the technical time, who will present first. And all the best to all of you.
Good morning to all the participants. I welcome all of you and give best wishes for their presentation. So we'll be starting with the first presenter. Nikhil, who is going to be present first?
Nikhil, you're on mute.
Dr. Ishani Pandey, please, you can start, Dr. Ishani.
Morning, everyone. The title of my poster is A Novel Approach Towards Behavioral and Psychological Symptoms of Dementia Management in the Oldest Old Age. Here we are referring to ages beyond 90 in this category. Now, dementia is the loss of cognitive functioning to the extent that it interferes with a person's daily routine functioning. With the incidence rate being very high at these ages, even the diagnostic challenges and underlying neuropsychiatric symptoms are strikingly different. Here we will be discussing about our management approach towards BPSD in 2 patients. In the first case, we have a 96-year-old hypertensive female with complaints of forgetfulness, irritability, anger outbursts, suspiciousness for 30 days. Her MMSE score was 8, MoCA score 6, neuropsychiatric inventory score 52, and she was kept on a diagnosis of major neurocognitive disorder and was treated on an inpatient basis. She was initially started on a low dose of 12.5 milligrams of quetiapine and 2.5 milligrams of memantine, citing no improvement. Her quetiapine dose was increased to 25, but due to sedation, 1 milligram of risperidone was started instead. Subsequently, memantine was also increased to 10 milligram, and along with it, 300 milligram of tablet sodium valproate, 100 microgram of tablet clonidine, and 5 ml of syrup melatonin was added. Since this showed improvement, so this treatment regimen was continued. Now, in the second case, we had a patient with an almost identical profile. So because of improvement in the first case, a similar treatment regimen was followed and improvement was seen in this patient as well. Now, coming to discussion, the prevalence of dementia.
Can you scroll down your presentation?
Yes, ma'am. Now, coming to the discussion, the prevalence of dementia increases with age, and also in this category of old age patients, some risk factors lose their effects, while some have the opposite effects on the risk of dementia. For example, in ages under 74, hypertension was a risk factor, but it was protective in ages more than 85. This can thus be considered as a possibility for the occurrence of symptoms at such an advanced stage in our patients. The pharmacokinetics and dynamics also change with age, but the treatment strategies are virtually the same for all ages. So the research regarding the management of BPSD in old age group is scarce. Now, keeping in mind the available strategies, we adopted the start low, go slow approach, but due to no improvement, a more rigorous approach had to be undertaken. So the patients were then started on an increased dose of a high potency antipsychotic, which was risperidone, dose being 1 milligram, along with 300 milligrams of an anti-epileptic mood stabilizer, sodium valproate, and 100 microgram of a sympatholytic. Now, this treatment regimen showed noteworthy improvement without any significant side effects. However, the results seen in these cases are short-term, and for more concrete results, more trials of this regimen is required on a larger number of patients. These are my references. Thank you.
Okay. Thank you. Is there any query, any question to Isani?
I think there is no question in the chat box till now. Ishani,
Yes, ma'am.
What do you think? What is the different type of symptoms? As you said, there is a difference in the symptoms compared
Yes, ma'am.
with the oldest old age and age group of 65 to 75. What are the basic difference you have found?
Ma'am, the caregiver burden is more, and it is more likely than that patients in the old age group, because due to lack of a caregiver, they have less access to a health facility. Whereas in cases of the younger elderly, due to the presence of caregiver, they have more access to that. And in the old age, there are more cognitive symptoms. And in these ages, there are more depressive symptoms and anxiety symptoms.
Thank you.
Have you assessed side effects?
Sorry, sir?
Have you assessed the side effects of these drugs like risperidone?
Sir, when we administered these drugs in our patients, there were very like I mentioned, because of quetiapine, there was sedation. But on this treatment regimen, there were no side effects, sir.
No extrapyramidal side effects on?
No, sir. No, sir. Even on follow-up, we saw that there was improvement and there were no side effects, sir.
Okay. All patients had mobility above
Yes, sir. Yes,
oldest of the old?
Yes, sir.
Okay. There was no issues with mobilities and other things?
No, sir.
Any other query?
So should we move to second presenter?
Yes, we can move.
So second presenter is Dr. Yadav Govind.
Thank you, sir. Thank you, ma'am.
Good.
Just a query.
Yes.
No, not with the presenter. Dr. Nikit, whether the timing is 3 minutes, right, for each presentation? Because we have to time the score also.
Yes.
Yeah, we have finished in 3 minutes. I was watching.
Thank you, ma'am. Thank you.
So next presenter.
Second presenter is Yadav Govind.
Problem in sharing my screen.
Yes. Dr. Govind, are you there? Yes, I can see.
Yes, ma'am, but there is problem in sharing my screen.
What are the issues you are experiencing?
Dr. Yadav?
Hello, ma'am. Can you please give me some time? Can I take some time?
Yes,
Can we then move on to the next candidate, because there are 14 candidates and we are time bound? So if we can move to the
after this
next
candidate, you can present your paper, Dr. Yadav. After the next candidate. Till now, you prepare your presentation.
Okay, it's coming.
Yes.
Probably.
Yes, start.
Okay, so we will start with you, Dr. Yadav.
Okay, Yadav Govind, all the best to you.
So start, Dr. Yadav.
Good morning, sir. I am going to present the topic study of effect of thiopentone and propofol on cognitive status of patients treated with ECT. First is introduction. ECT is commonly used treatment for major psychiatric illnesses. Cognitive impairments continue to be the main complication of ECT. It can be due to many factors like electric charge, duration of seizure. General anesthetic agents may influence cognitive status of patient after ECT. Thiopentone and propofol are commonly used anesthetic agents during ECT. So aim of our study is to assess the effect of thiopentone and propofol on overall cognitive status of patients treated with ECTs and to compare thiopentone and propofol as an anesthetic agent for ECT with respect to effect on overall cognitive status of patient after ECT. Materials and methods. In this prospective observational study, 10 patients in age group between 18 to 50 years suffering from various psychiatric illnesses and planned for ECT treatment were included. Patients having neurocognitive illness and those who received ECT in last 6 months were excluded. Sample divided into two groups, thiopentone and propofol, each having 5 subjects. After careful pre-anesthetic evaluation, all patients received glycopyrrolate 0.1 mg per kg IV. In propofol group, sedation was achieved with propofol 1.5 mg per kg IV. In thiopentone group, sedation was achieved with thiopentone 3 mg per kg IV. Succinylcholine 0.4 mg per kg IV was given to reduce muscle contractions. Bilateral ECT was administered twice a week using a brief pulse ECT device. Total electric charge in joules and duration of seizures in seconds was recorded after each ECT. All patients were evaluated using MMSE scale the day before the first ECT and the day after the 6th ECT. Data obtained were analyzed using the software SPSS version 11, T-test, Z-test, MW test, and Wilcoxon test. It's not scrolling.
Okay, you continue. Continue, Dr. Yadav. Just 30 seconds.
Result: the mean age of patients, mean year of schooling, mean number of ECTs, and mean duration of mental disorders in both groups was statistically similar. Almost all the patients receiving concurrent psychopharmacological treatment. Mean total charge delivered to patients in thiopentone group was less as compared to propofol group, probably due to an elevation in seizure threshold caused by propofol. Mean total duration of seizure was more in thiopentone group, that is 163.8 seconds, as compared to propofol group, that is 126.2 seconds. In thiopentone group, mean pre and post ECT MMSE score was 27 and 28 respectively. And in propofol group, mean pre and post ECT MMSE score was 27.6 and 25.4 respectively. This difference in mean MMSE score was statistically significant, that is p-value is less than 0.05. So the cognitive impairment in thiopentone group was less as compared to propofol group. The relationship between the pre-ECT score and post-ECT score is shown in the graphs.
Our time is up, Dr. Yadav. It's almost 4 minutes.
Discussion. Most of previous studies have compared thiopental and propofol with regard to cognitive status in the immediate post-ictal period after ECT use. Our study has compared thiopental and propofol with regard to overall cognitive deficits after ECT. For that, we assessed cognitive functions of patients before first ECT and after last ECT. Conclusion of our study is, although propofol is good alternative to thiopental in high-risk patients, thiopental has significantly less effect on overall cognitive status of patients than propofol. Thank you, ma'am.
Thank you. We took almost 4.5 minutes. So now there is only 1 minute left for discussion. You said its sample size was just 10 patients.
Yes, ma'am.
Yes, I think it's less for the study. And have you assessed the patient immediately after 6 ECT, means last ECT, or later on also? After a
No, ma'am. We assessed 2 times, before the first ECT and after the last, that is 6th ECT.
But after how many
After
days?
that, we could not assess the immunity score of the patient.
Okay.
After how many days of the last ECT?
1 day after the last ECT.
1 day after that. Okay. What is the design of the study?
Study is observational study.
It's an observational study, but you are applying ECT. It becomes an interventional study.
Regularly we use the propofol and thiopental in ECT as our regular.
Yes, that's okay. But the thing is that you are applying external agents and comparing to external agents in a group of persons who are getting what we call electroconvulsive therapy. This makes it an interventional study. Number 2, was there any ethics committee approval in this study?
Yes, sir. Approval from ethical committee was taken.
Okay, it was not mentioned in the. And another part is that if you use any statistical tool, it's again a good practice to mention about whether it's a licensed person or not, because these are other things that people used to use. So regarding the tools, whether it's a thing, there are certain issues like responsible code of research. Do you know the different responsible code of research?
No.
Okay.
Well, just a comment, Dr. Yadav, your 4th reference is 1955. I wish we would have got some recent reference.
Okay, sir. Yes.
I think we can move on to the next.
Thank you, Dr. Yadav.
Thank you, ma'am.
So next presenter is Dr. Sheikh Mujahid.
Good morning, everyone. Am I audible, sir? Good morning, everyone.
So please do the slideshow, sir.
Yeah, slide is already shared.
So can you do the full screen?
I have already shared my presentation.
No, you do it full screen.
Yeah, it is full.
The slideshow.
It's on slideshow.
Okay, you start. Your time starts now.
Good morning. My presentation is on a case report of catatonia, partially refractory to lorazepam and treated with zolpidem. First of all, introduction. Catatonia is a psychomotor disorder associated with various mental and neurological disorders, which is characterized by variety of motor symptoms, including stupor, posturing, epilepsy, passive flexibility, mutism, negativism, mannerism, stereotypic behavior, and extreme agitation. It is a psychiatric emergency and it increases the risk of certain medical complications and mortality. Catatonia effectively responds to lorazepam and ECT, and lorazepam is considered as first line of treatment irrespective of the underlying cause. Although benzodiazepines are used extensively to treat catatonia and accepted to be the first choice, but they demonstrate only around 79% remission rate. And zolpidem, like benzodiazepines, is a positive allosteric modulator of GABA A receptor, but it specifically binds to the alpha 1 subunit of GABA A receptor, unlike lorazepam, which non-specifically binds to different subtypes of GABA A receptor. My case was a 45 years old male, married Hindu with history of psychiatric illness. He was schizophrenic since last 2 years, and no family history of no family history was admitted in medical ICU of our institute for progressive deterioration in his physical and mental state. At the time of admission, he was unkept and non-verbal. He also developed waxy-flexibility, negativism, and catalepsy. He had stopped drinking water and eating for 6 days. Initial investigations, including CBC, RBS, liver function test, kidney function test, serum electrolytes, serum ammonia, and CPK and MRI brain was within normal limit. Psychiatry reference given, we diagnosed as catatonia as per DSM-5, Busch-Frank-6 catatonia rating scale. Score was 27. Injection lorazepam 4 mg infusion given. He showed improvement in his symptoms after a few hours. He started talking and responding to commands. He was started on lorazepam 4 mg intravenously three times a day, along with supportive therapy. He remained asymptomatic for 1 day, and injection lorazepam continued, but again he became unresponsive and new. He showed increased heart rate, increased blood pressure, increased secretion and rigidity, both upper and lower limb. Tablet zolpidem 10 mg started in view of no response to lorazepam. He responded well to tablet zolpidem with gradual resolution of symptoms. He was then started on oral zolpidem tablet 30 mg thrice daily in divided doses. 30 mg in divided doses. Injection lorazepam gradually stopped, and modified ECT was also initiated later after anesthesia fitness. 4 sessions of ECT given. Patient improved within 7 days and was discharged on the same. No relapse of symptoms on follow-up. My conclusion of this presentation is zolpidem may be beneficial in lorazepam resistant cases of catatonia. It can be tried before ECT and in cases where ECT is contraindicated or restricted. Although the evidence in favor of zolpidem for treatment of catatonia is stark, it may be an effective treatment in lorazepam resistant cases, but larger studies are required to confirm zolpidem's efficacy.
Thank you, Dr. Sheikh. You have used ECT also along with zolpidem and lorazepam. So how do you claim that this improvement is because of zolpidem?
ECT was started after 3 to 4 days of zolpidem, because patient was not fit for in anesthesia point of view to initiate ECT.
So what was the reason for starting ECT if the patient had improved?
Ma'am, because we have used zolpidem for the first time, so for augmentation, and zolpidem was used as an adjuvant therapy for this case.
And during catatonic state, the patient was able to take orally when you claim that lorazepam was not working.
Yes, patient was completely bed rest, and he was given tablet through the nasal tubes.
So you have administered ECT because zolpidem failed?
Sorry, sir.
Means ECT was applied because of failure of zolpidem? Or
No, sir. The patient has showed respond to zolpidem. He was improved. His catatonic symptoms were improved, but after 3 to 4 days of zolpidem therapy, we started ECT.
What was the logic? Because if he was improving, then
Yes,
what was the logic of starting again ECT?
So because all his catatonic symptoms were not improved. He still had rigidity and flexibility is still was present there.
So that says zolpidem was not effective.
But his other symptoms like mutism and catalepsy and autonomic dysfunction had gone.
Anyways, these symptoms in what we call catatonia, it comes and goes. It's not that it will be there for 24 hours or so many days.
But because previously patient was not fit for ECT, so we had started him on zolpidem, and he showed improvement. And even after the ACT therapy over, we kept him on zolpidem 10 mg tablet for 7 days. And on follow-up, patient showed no any catatonic symptoms. And after 2 to 3 months of follow-up, patient developed no relapse of symptoms.
Why? Means initially he was not fit for ECT.
So patient was not fit in anesthesia point of view. He was admitted in ICU. So there was concern about his medical illness.
He has a medical illness.
Yes, sir. He has some ECG changes, but later cardiologist gave consent, cardiologist gave permission for ECT.
So he didn't got consent for ECT for initial days. That's the reason, or he was medically unfit for?
He was medically unfit for.
So what was the reason for medically unfit? Means the specific call for medical unfitness.
Sir, his ECG showed some abnormalities.
The ECGs have become normal in 3 or 4 days.
Yes.
Okay.
Dr. Sheikh, you have not mentioned any references of zolpidem and catatonia. It's there in the literature.
I have mentioned. So reference number 5 is for zolpidem.
Okay, thank you.
Okay, Dr. Sheikh, I think we had taken 3.5 minutes for presentation and further 3 or 4 minutes for discussion. Thank you.
Thank you.
So next presenter is Dr. Naina Aswar.
Yes, sir.
Okay, Dr. Naina, you start.
Yes, ma'am. Good morning to all. Today my topic is psychiatric manifestation in patients of the Gaucher's disease. It's a rare case report of 14-year-old boy. So the Gaucher's disease is basically a lysosomal storage disorder, which is classically divided into 3 types. Type 1 is differentiated from type 2 and 3 disease by the absence of nervous system involvement. Gaucher's disease may present with the psychiatric manifestation as a part of the wide spectrum. As we can see in the image given on the right side, the circle one, which shows the type 3 having around 5% in total. And the type 1 is more common than the among the 3 of the Gaucher's disease. So the medical aspect of Gaucher's disease are well studied. However, the less attention was directed to its psychological manifestation. Multiple studies shows the depression, anxiety, schizophrenia, or tic disorders. So this case report focused diagnosed case of the Gaucher's disease type 3 with intellectual disability, with behavioral disturbance with seizure disorder. So my case report is 14-year-old boy was diagnosed, who was diagnosed case of the Gaucher's disease, was brought by the mother to OPD with complaints of irritability, aggressive towards parents, pulling nails, spitting, lip biting, skin excoriation since last 1 year, and mother also observed the decreased scholastic performance. He had generalized tonic-clonic movements with loss of consciousness since last 6 months. Patient diagnosed with the Gaucher's disease is since last 10 years. Since then, he is on the enzyme replacement therapy. So he had behavioral symptoms also. So investigation we have done was IQ assessment by Vinland Social Maturity Scale. It was a 68. We did the complete blood cell count and chest X-ray, which was normal. Electroencephalogram showed the spike and wave discharge. 2D echo had shown the tricuspid regurgitation with normal biventricular function. So to help with his behavioral disturbance, we have counseled the family members and educated for the supportive therapy. Also, we started him on the low dose of the atypical antipsychotic for the behavioral disturbance. And on the follow-up also, when we have observed the patient, he had improved with the behavioral disturbances, and intellectual disability was as it is. The IQ was again the 68 only. These are my references.
Dr. Naina, you have finished in time. Can you tell me in which ethnic group this disorder is more common?
Which age group, ma'am?
Which ethnic group?
Ashkenazi Jews have more common in this.
And which enzyme is deficient in this?
Beta glucocerebrosidase.
Okay.
Hello, Dr. Naina.
Yes, sir.
Yeah. So if you need to assess disability in this patient,
yes, sir.
What are the areas that you will look into?
With respect to intellectual disability, we will look for his comprehension and also the calculative memory, and how his scholastic performance is, because mother was more worried about the decreased scholastic performance. So we will focus on that.
No, I was actually, will it be, means what are the areas that needs to be? That's according to the intellectual disability only, which is very mild, 68, no?
Yes, sir.
In fact, this will not be a what you call sufficient to get a disability certificate.
Yes, sir.
So, what are other? Does he become eligible for anything regarding multiple disability in this case?
Sir, he can because for Gaucher's disease, he may land up into the bone deformity also, kyphoscoliosis or something. So if he have in that, so he may get the other disability, if not intellectual disability.
No, as per the this RPWD Act, no?
Yes, sir.
There are different conditions in which what are the conditions he is having that may give a he may what we call combined disability score based on these multiple disabilities that he has. One is okay, it's a mild mental retardation. That's then a congenital health problem, then epilepsy also, which is a CNS problem, no?
Yes, sir.
Was it controlled, uncontrolled?
It was controlled, sir.
It was a controlled seizure. Okay. So you will need to have a what we call view of a combined medical board for.
Yes, sir.
Dr. Naina, your title should have had case report, because it's not a study, it's single case you are demonstrating.
Yes, sir.
Thank you, Dr. Naina.
Thank you, ma'am.
We move to next presenter.
Next presenter is Dr. Siddhanta Mathur. Dr. Siddhant.
Good morning, sir.
Dr. Siddhant, start screen sharing.
Yes, ma'am.
Start. Just go for slideshow.
Right, ma'am. Can you see it, ma'am?
Yes, you can start.
Good morning, everyone. Good morning to the faculty and my fellow presenters. My name is Dr. Siddhant Mathur. I'm from MGM Medical College, Aurangabad. My poster's topic is Attitudes and Perception of Undergraduate Medical Students Towards Mandatory Attendance. As we know, Indian education policies are designed around the idea that mandatory attendance is necessary to ensure uniform academic performance in a class. Research on class attendance shows that students with higher attendance perform better academically. Attendance in classroom has major impact on the development of students' careers. In this study, we qualitatively evaluate the opinion of undergraduate students regarding the mandatory attendance criteria to understand what modifications should be made to benefit the students. The aim of the study is to qualitatively study the attitude and perception of UG medical students regarding mandatory 75% attendance for theory lectures and clinical postings. The methodology, the study was conducted in MGM Medical College, Aurangabad over a 2-month period. The total sample size was 247 students, which were equally divided between male and female. The study population was students from second, third minor, and third major year. The study tools that were used were a preset semi-structured questionnaire, which was reached after having a pilot interview with a few students from the same class. According to the study, the students revealed that the biometric attendance should only be reported to the students. We identified the major reasons for absenteeism in the class. The commonest reasons were preparation for college examination as told by 155 students, attend online and offline coaching classes for entrance exam by 147 students. 112 students believed that it was poor teaching skills of a teacher. 110 students said that hectic daily schedules or too much information in limited time was provided in class. 80 students said that there was availability of other entertainment options, so they did not go to the class and bunked it. 68 students had a lack of interest in the subject. 67 had health-related issues, and 59 students reported lack of confidence and self-esteem. The impact of compulsion of attendance, according to students, it gave them 74.5% reported that it gave them less time for preparation of exams. 67.6% reported that there was less time for completion of journals and other mandatory assignments. 67.6% also reported that there was an inability to set their own daily routine as per their wish. 61% reported there was less time to interact with family members. And 51% reported that there was less time to interact with friends other than college friends. Also, there were a minority of students, respectively 31% and 30%, who said that compulsory attendance led to an increase in academic performance and an increase in interest in the subject. From that subjective opinion of the students, it may be concluded that attendance should not be mandatory, at least for the preparatory period of examinations. Students may be given the liberty to decide and arrange for lectures according to their need. Total duration of college hours could be reduced to allow students more personal time for studying and recreation. Extracurricular activities may be arranged for students more frequently to improve their confidence and teach them how to work efficiently in collaboration with others as a team. Also, arranging guest lectures could help increase their interest in the subject. Mentorship programs under faculty could be organized so that better feedback can be obtained from these students on a regular basis. Thank you so much. These are my references.
Dr. Samar, Siddharth, almost 4 minutes for your presentation. I have a question. What do you mean by students should have a liberty to decide curricular activities and arrange lectures? And who will take the responsibility from students' side?
Right, ma'am. As per my references, there were studies conducted in different countries than India where students did have the liberty to select their elective subjects as per their choice. In one study, I have also read that it happened in a medical school. In other studies, it usually happened in schools of other streams. And the responsibility should fall upon the class representatives, which can be appointed on the basis of performance by the faculty itself. And some students also reported a deep connection towards the first year teachers. So I think the first year teachers should be the one who should hold the responsibility to identify these class representative in the first year itself, so that it can help them further in their medical school.
Do you think your colleagues will be able to decide which lecture should be taken and which part should be omitted, because they are of the same age group and same experience?
Yes, ma'am, I understand that it is a proposition that will require great responsibility, but till the time we do not allot this great responsibility to the students, they cannot be an active part. They cannot be have an active part in their own future. So I think the responsibility should fall upon the students itself, as per the qualitative experience of the students.
Dr. Srikanth, was there any ethics committee approval? We didn't see anything mentioned.
Sir, yes, ethical committee approval was taken. Also, a pilot study was conducted with 25 students to basically set the preset questionnaire that we have here to identify the impact of compulsion on attendance and different factors. So we conducted an interview of about 25 students after permission from ethical.
It's the same college in which you are working, or it's a different college?
Yes, it's the same college in which I'm working. I'm working as a third-year resident here, psychiatry resident.
Same college. So the students become a vulnerable group here as per the ICMR guideline.
Sorry, sir, I didn't get that.
No, means ICMR has got a separate guideline, what they call issues regarding vulnerable people, in which students and say migrants or other group, they are also in the vulnerable group, and there are certain precautions that needs to be taken in those cases.
Okay, so we did make sure that the study was anonymous and the students were given were not pressurized. They were welcome. The students who wanted to join the study, they were given these preset questionnaires in class itself.
Was the investigators were also anonymous?
So the investigator, till the time data analysis were done, was anonymous. So one of the investigator was me, and the other was pharmacology associate professor. Both of us remained anonymous till the time data collection and sample collection was complete.
Thank you, Dr. Siddharth.
Thank you.
Presenter.
Yes. So next presenter is Dr. Rishabh Chandra.
Yes, sir.
Dr. Rishabh, please share your screen.
Yes, ma'am. Just a moment. I have to reopen the Zoom app. There is some problem with screen sharing. So give me
the next presenter, and then
sure, ma'am. Thank you.
Who is next?
Yes, Dr. Nirmay Sachdeva.
Yes, Dr. Nirmay.
Nirmay Sachdeva.
Yes, good morning, ma'am. Good morning, sir.
Good morning.
Good morning. Yes, you can start now.
Good morning, everyone. I am Dr. Nirmay Sachdeva from Career Institute of Medical Sciences, Lucknow. I am going to present my poster on the topic of study on the prevalence and correlates of...
do on slide share. Go on slide share.
A study on the prevalence and correlates of postcoital dysphoria among sexually active men in a metro city from North India. Traditionally, the human sexual response cycle has been conceptualized in terms of a physiological model with response to excitement, plateau, orgasm, and resolution phase. The experience of the resolution phase, however, remains under-researched and therefore poorly understood. It is commonly believed that males and females experience a range of positive emotions, including contentment and relaxation immediately following consensual sexual activity. There is evidence that a counterintuitive phenomena known as postcoital dysphoria may occur following otherwise satisfactory consensual sexual activity and is characterized by inexplicable feelings of tearfulness, sadness, or irritability. The psychological phenomena of PCD is distinct from a rare physiological condition experienced by a male called post-orgasmic illness syndrome, which is believed to be an autoimmune response to semen. However, individuals who experience postcoital dysphoria may express their immediate feeling after sexual intercourse in terms of melancholy, tearfulness, anxiety, irritability, psychomotor agitation. Previous studies have shown 41% of men experience PCD in their lifetime and 3 to 4% on regular basis. The study aims to estimate the prevalence of and correlates the postcoital dysphoria among sexually active men in a metro city from North India. Materials and method. An online survey was conducted by a social media platform such as Facebook or WhatsApp. A total 200 men participated in the survey with the help of Google Form. A semi-structured pro forma for demographic details and post-sex experience scale was used. A total 32 individuals were excluded from the study due to medical, sexual, or psychological illness. And finally, we assessed 168 sexually active men. Inclusion criteria were married and unmarried sexually active men, individual aged between 18 to 55 years, and those who are willing to participate in the study. Exclusion criteria, the individual, those are less than 18 years and more than 55 years. Sexually active males, individuals suffering from any medical, sexual, or psychological illness, and those who are not willing to participate in the study. Methodology: an online form including a questionnaire for demographic details and post-sex experience scale was shared with the recruited individuals. Post-sex experience scale is a validated scale developed by School of Psychology, Queensland University of Technology, Brisbane, Australia. This scale inquired questions which were broadly classified as question assessing in the following domains. First, a sense of sexual alienation. Second, positive correlation with self. Third, feeling connected with the partner. Result: out of 168 individual, majority 152 belongs to less than or equal to 35 years. 83.3% were married males, 84.5% were Hindu, and the mean age of all participants were 30.15. The overall prevalence of PCT was found as 45.2, while it is significantly more in unmarried than married. PCD in the young adults and PCD is more in young adults than middle-aged men. Discussion.
Continue.
Yes. Men's experience of PCD.
You are not audible, and I think you are already
Audible.
Hello.
Dr. Meena, you are not audible.
Discussion. Men experience. Men's experience of resolution phase and PCD in particular remain under-recognized and unresearched. Thus, the primary purpose of the study was to explore the dimensionality of post-sex experience among males. Post-sex experience was studied under three domains: sexual alienation, connection with self, and feeling connected with the partner. Sexual alienation refers to the general dysthymia, which may be characterized by a range of feelings varying from emptiness to loneliness, regret, and extreme agitation and fearfulness. Connection with self comprises a range of experience, often associated with a sense of security, desire, joy, and contentment. Feeling connected with the partner is essentially an interpersonal dimension that relates to a sense of closeness and emotional connection with the partner. Limitation: It is possible that responder had never before considered their personal experience following sex and therefore answered in a way that aligned with popular cultural belief that how one should feel. Conclusion: the finding of the current study suggests that a significant proportion of men experience PCD in their lifetime. This study contributes significant to our limited understanding of post-coital dysphoria. These are the reference of my study.
Thank you, Dr. Nirnay.
Thank you.
You have almost crossed the time limits. Dr. Kamal, do you want to ask anything?
No, it's okay, madam. Only part is I haven't also seen any ethics committee part here. That's and it's
yes,
a very
sir.
sensitive issue.
Yeah, can I ask a question, ma'am?
Yes.
Dr. Nirnay, whether you have applied this checklist for online surveys?
Sir, we have used as a post-sex experience scale.
And checklist for online surveys, cherries, that is, to basically cover all the how it is supposed to be done. There is a checklist. So have you applied that?
Sir,
any study which we do now, online surveys is supposed to do with the checklist, which by cherries it has to be covered. Kindly look into it, and you can subsequently include in a paper. Thank you.
Thank you, Dr. Nirnay. Then we will move to another participant.
If Dr. Rishabh Chandra is ready, then we can invite him.
Yes, sir. I'm ready. So can you see my screen?
Yes, just keep it on the slide share mode.
Okay.
Ma'am, did he follow his timings?
No, he had overshooted the timing. He had took 5.5 minutes.
Thank you, ma'am.
May I start?
Yes, your time starts now.
Good morning, everyone, respected chairpersons and teachers. The topic of my present poster is effect of seasonal variation in the occurrence of delirium in patients admitted to intensive care units of a tertiary care center in North India. Delirium can be defined as an acute brain dysfunction characterized by transient and fluctuating changes in the state of consciousness, accompanied by cognitive impairment, which frequently affects patients admitted to ICU. The prevalence of delirium in critically ill patients varies between studies and can affect approximately 80% of patients on mechanical ventilation admitted to ICU. However, only 32 to 66% of patients are correctly diagnosed and treated. Recently, it has been shown that even among healthy subjects, cognition function, especially attention and executive processes, may peak in late summer and early fall and decline in late winter and early spring, with a more dysfunctional pattern during winter. The possible underlying mechanism of this seasonal influence may be related to changes in light darkness cycle or lower vitamin D levels in winter. Materials and method: a total of 720 patients who were admitted in the ICU of a tertiary care center in North India between July 21 to June 22 were recruited for the study. The inclusion criteria used were the individuals aged between 18 to 85 years, both genders, who passed through the intensive care unit and who were willing to give the informed consent. Exclusion criteria was individuals aged between less than 18 years, non-ICU patients not willing to participate in the study or having any pre-existing psychiatric illnesses. Methodology: patients were screened using Richmond Agitation Sedation Scale and Delirium Observation Screening Scale. Confusion assessment method: intensive care unit was used to assess the delirium. The incidence of delirium and length of stay was summarized by season and statistically analyzed. Out of the 720 patients admitted to ICU, 158, that is 21.94%, had delirium, and 64 of whom were females, that is 40.5%, and 94 were males, that is 59.5%. Incidence of delirium was more in winter, that is 57%, than in summer, that is 43%. So the length of stay, length of stay in the hospital in patients with and without delirium. So 158 patients with delirium, the mean stay was 23.25. whereas in 562 patients without delirium, the mean stay was 4.5. The mortality outcomes with
You are not audible.
ma'am, there is a bit of problem moving the.
You are already past 3 minutes.
Yes, ma'am. Coming to the discussion in the study, we found the incidence of delirium in 21.94% individuals, that is 158 patients, of which 90 patients reported in winter season, whereas 68 patients were reported in summer season. Study by Da Silva Mercado et al. Shows a 30.1% prevalence of delirium. Mean hospital stay of delirium patients was 23.25 days, which was significantly higher than non-delirium patients. Gallerani, M, and Manfredini reported that events of delirium were more frequent in winters, that is 26.6%, and in summer, that is 23.4%. Mortality rate in present study was 38.6%, that is 61 patients. Of 61 patients, 37, that is 41.1% patients died in winter season, with 27.1 mean of length of hospital stay, and 24 patients, that is 35.3 patients died in summer with a mean stay of 19.3. The findings of Da Silva Mercado et al., who reported significantly higher hospitalization for delirium cases, the p-value is less than 0.5%. Conclusion: the study indicates higher rates of occurrence of delirium in winter than in summer months. We can infer that the longer the patient spends in intensive care unit, the greater the chance of delirium. Therefore, preventive and interventional measures are needed to reduce the mortality rate in patients with delirium, and early detection is an excellent tool to improve this outcome. Recommendation: the role of possible underlying favoring or triggering factors deserves further research, and these are the references I've used in my study.
Thank you, Dr. Rishabh. You took almost 5 minutes. I have a question.
Yes, ma'am.
Said in materials method that patients who are willing to give consent were taken in the study. But if
yes, ma'am.
delirious state, how is it taken?
No, ma'am. The family members, the family members who gave the consent for their patients.
And you claim that it is more common during winter than summer.
Yes, ma'am.
What do you think?
Yes, ma'am.
Because of long nights in summer, sundown phases early in winter, that's the reason, or there is something else?
Ma'am, the reduced daylight during the winter season is probably the reason.
Okay. Dr. Kamal, sir?
Yeah. Dr. Rishabh, was it a retrospective study or is it a prospective study?
The prospective study.
So prospective study for 1 year?
Yes, sir.
Thank you, Dr. Rishabh. Now we'll move to next participant.
So next participant is Dr. Vaishali Sehgal.
Yes, sir. Good morning, sir. Good morning, ma'am.
Good morning.
Ma'am, is my screen visible?
Yes. Now you can start.
Okay. Good morning, everyone. The topic for my today's poster presentation is acute onset psychosis in a patient of tuberous sclerosis, a case report. Introduction. Tuberous sclerosis complex is a multisystem autosomal dominant disorder caused due to mutation in genes TSC1 or TSC2 with a prevalence of around 1 in 6,800 individuals. An array of neuropsychiatric illness known as tuberous sclerosis complex associated neuropsychiatric diseases, that is TAND, are identified in around 90% of people with tuberous sclerosis complex. And among them, psychosis has been reported only in around 2.3% of cases globally and rarely from India. So I am presenting a case of a 20-year-old gentleman with history of developmental delay and poor academic performance, with family history of alcohol dependence syndrome and cannabis use disorder in father, who presented to psychiatry OPD with complaints of fearfulness, suspiciousness, refusal to eat, hallucinatory behavior, and disorganized behavior for 4 days. Previously, he was diagnosed with childhood onset epilepsy and intellectual disability with behavioral disturbances, for which he was regularly receiving oral anticonvulsants and oral antipsychotics. On examination, there were few catatonic symptoms in the form of staring, posturing, and grimacing, as well as some extrapyramidal symptoms such as marked cogwheel rigidity, hypersalivation, slowness of movement, and postural tremors in upper limbs. Additionally, adenoma sebaceum was noticed on the face, over nose, cheeks, and chin. On mental status examination, he predominantly had visual hallucinations along with delusion of reference and persecution, and cognitive functions were impaired. On assessment, IQ was 41, suggesting a moderate intellectual disability. MASS, that is Modified Simpson-Angus Scale, score was 12, which signifying moderate degree of movement disorder. And Bush-Francis Catatonia rating scale showed staring, posturing, and grimacing. His acute symptoms resolved over a week after treatment with injection promethazine, oral trihexyphenidyl 4 mg, and oral olanzapine 5 mg, which was gradually increased to 15 mg. The investigations done were all the basic routine investigations, including the CBC, liver profile, kidney profile, thyroid profile, serum electrolytes, RBS, and ECG, which were within normal limits. MRI brain of the patient showed presence of cortical tubers, subependymal nodule, and subependymal giant cell astrocytoma, which was suggestive of tuberous sclerosis. Here are the pictures showing the green arrow in the first picture is showing the subependymal giant cell astrocytoma. Yellow arrow signifies subependymal nodules, and these blue arrows, they are signifying calcified subependymal nodules. And again in the third picture, yellow arrows, this signifies cortical tubers. Discussion. Psychosis has been reported only around 2.3% of cases of tuberous sclerosis complex globally. Cognitive impairment is common but not invariable. The distribution of cognitive ability in tuberous sclerosis complex has shown to be bimodal, as half of the population with normal IQ and 1/3 in profound range. The major CNS pathological manifestations of tuberous sclerosis are cortical tubers, which are the hallmark of tuberous sclerosis complex, subependymal nodule, and subependymal giant cell astrocytoma. This patient presented with acute psychosis, predominantly visual hallucinations, suspected an underlying organic pathology, which prompted a neurological reference. Since the subependymal giant cell astrocytoma was not compressing the nearby structures, no surgical dissection was further needed. And after 2 months of continued treatment, the caregiver reported improvement in psychotic and behavioral symptoms. Conclusion. This case highlights that tuberous sclerosis can present as acute psychosis in adolescent and in early childhood, and thus it should be suspected in patients having complex neurological manifestations such as marked visual hallucinations, catatonia, and epilepsy. These are my references. Thank you.
Dr. Vaishali, I think you have almost 4 minutes to finish your presentation.
Yes, ma'am.
You had done IQ assessment during patient's psychotic state or later on?
No, ma'am. When the psychotic symptoms were resolved, then IQ assessment was done after a week.
Kamal sir, do you want to ask?
Okay. Have you assessed for any geographical spot in the patient?
Sorry, sir?
Geographical spots.
Sir, on examination, clearly on face, adenoma sebaceum was visible. Like it was, adenoma sebaceum was visible over face, cheeks, and chin.
Okay.
No dermatological findings were seen.
Okay. Where is geographical spots found mostly?
Sir, so mainly over the trunk and the face.
Trunk over the face. Okay.
Yes, sir.
And patient was already on antipsychotic. Which antipsychotic he was taking?
Yes, ma'am. Previously, ma'am, he was already taking olanzapine and risperidone since he was diagnosed as a case of intellectual disability with behavioral disturbances. And because of that, the patient acutely presented with extrapyramidal side effects like rigidity, hypersalivation, and slowness of movements. So immediately the previous drugs were stopped and promethazine was given, and then later on he was started on antipsychotics.
Thank you, Dr. Vishal.
Thank you, ma'am. Thank you, sir.
So next presenter is Dr. Apurva Yadav. Dr. Apurva Yadav.
Yes, sir.
Am I audible?
Yeah.
Yes, you are well. You start your screen.
Yes, ma'am. Is my screen visible?
No.
Ma'am, is my screen visible now?
No.
Is my screen visible now? ma'am?
Yes. Yes.
Yes. Just go on slide share mode.
Good morning, everyone. I'll be presenting a case of schizophrenia with dancing eyes, the neurodevelopmental hypothesis, under the guidance of Dr. Pradeep Patil, who is my HOD. Introduction, nystagmus or the dancing eyes. Nystagmus or the dancing eyes is a congenital disorder which is characterized by rapid involuntary eye movements. Coloboma is an ophthalmic condition characterized by the keyhole appearance in the eye structures. Schizophrenia is a chronic, complex, and disabling mental disorder having a complex presentation with multifactorial cause. Studies have reported that close to 70% of schizophrenia patients have untreated visual acuity problems. The neurodevelopmental hypothesis of schizophrenia suggests that certain processes which occur in the early developmental stages and or in utero can contribute to the pathogenesis and severity of schizophrenia. So I'm presenting the case summary. An 18-year-old female presented with complaints of suspiciousness, smiling to self, irrelevant talking, and hearing of voices not heard by others in the last 4 months. 4 months back, patient's mother noticed that the patient would not sleep till late at night and would smile and mutter to herself as if she's talking to someone. When a mother would ask her to sleep, she would get irritable and would also start abusing her. She would also say that her neighbors are conspiring to kill her and would ask her mother not to allow any guests to come at home, especially her neighbors. She would say that she hears female voices of 3 unknown people discussing about how to kill the patient, and the voices would abuse the patient frequently. Birth history, patient was born prematurely with low birth rate, cried approximately 1 hour after birth. The prenatal period suggests increased maternal stress during the second trimester due to patient's father's demise. Personal history, according to her mother, she always had difficulty in reading and seeing far objects during school days, but never wore any visual aids. On mental status examination, hallucinatory behavior was observed, along with rapid side-to-side movement of both eyes, delusion of reference, delusion of persecution, and third-person auditory hallucinations were present. On physical examination, involuntary fast eye movements from side to side and diminution of vision in both eyes was observed, with keyhole appearance of the pupil. Ophthalmologist opinion was requested, and she was diagnosed as a case of congenital microcornea with nystagmus and coloboma. Patient was provided the best corrected visual acuity possible by the ophthalmologist. Low vision aids was advised in case of deterioration of vision in the future with 6 monthly follow-up. Patient was started on tablet olanzapine 10 mg HS and tablet clonazepam 0.5 milligrams and was asked to follow up in 2 weeks. The patient showed improvement on her first follow-up. There was overall 40 to 50% improvement in her overall symptoms. In this picture, we can clearly see the keyhole appearance in both the eyes of the patient. Discussion. Although visual impairments are common in schizophrenia, it is unclear to what extent these originate in the eye and the brain. It can contribute substantially to poorer real-world functioning in people with schizophrenia, and therefore eye movement dysfunction may be an important trait marker for schizophrenia. My case report suggests evidence which points to the neurodevelopmental model in which developmental insults like maternal stress can lead to the activation of pathological neural circuits and can cause psychiatric problems during adolescence. An ophthalmologist opinion becomes necessary in such cases, which can further help in providing necessary help to such patients, hence improving their quality of life. Poor performance on test of visual perception is assumed to reflect the process under investigation, and little attention has been paid to the possibility that reduced visual acuity could play a role. Conclusion, this case suggests direct relation between ocular deformities and schizophrenia spectrum disorders later in life, which further supports the neurodevelopmental hypothesis of schizophrenia. Such ocular abnormality should be suspected in patients with psychiatric illness, which can lead us to a better understanding of the extent of the disorder with or without visual impairments in patients with schizophrenia. These are my references.
Thank you.
Thank you, Dr. Apurva. You took almost 4 minutes for your presentation.
Okay, ma'am.
Can you tell me, according to various studies, what is the incidence of psychosis in this congenital microthumia with nystagmus and coloboma?
And there was a like in particular nystagmus and coloboma, I don't know, but I read a study in which there was a sample size of 200 people, out of which 70% of the patients with schizophrenia had visual acuity problems, and coloboma was there.
Yes, Dr. Kamal, sir.
Okay.
Anyone want to ask question? Should we move to another?
Just that your third reference is a book review. So I didn't get that.
Okay, sir.
Yeah, thank you.
Okay, sir.
So next presenter is Dr. Gajanan Mukde.
Yes, Dr. Gajanan.
Good morning, everyone. Myself, Dr. Gajanan Mukade. I'm from the Government Medical College, Miraj. Is my screen is visible to everyone?
Yes. Now go to slide share more. Slide share more.
Is it visible to everyone now?
Yeah.
Good morning, everyone. Myself, Dr. Gajanan Mukade. I'm from the Government Medical College, Miraj. My topic of poster presentation is to study stress and psychological well-being in mother of intellectually disabled children in rural area. It is a cross-sectional observational study. Intellectual disability is a impairment in cognitive function, that is the reasoning, learning, problem solving, and the adaptive behavior like conceptual, social, and practical skill. Intellectual disability is 1.5 times more common among the males than the females. 50% of the, as per the 2011 census, in India, 50% of the children are suffering from the intellectual disability. So caring of such child is more stressful, and also the stigma from the society. The newly couple dream about their child. Dream child and the actual child is the maybe the bad source of attitude and the presenting parenting stress. When child misses the developmental milestone, mother go through the grieving process. So mother deal with the issue related to the child disability, delayed developmental and behavioral issue. So we have conducted study on the caregiver, mother of intellectually disabled children. Study conducted after the ethics committee approval conducted on the 50 mothers. We assessed mother regarding the stress and the psychological well-being by using the perceived stress scale and the psychological well-being scale. In psychological well-being scale, have 5 domains. That is the satisfaction, efficiency, sociability, mental health, and the interpersonal relationship. The score score for psychological well-being is between 15 to 250, again, which is divided into the very low, moderate, and high and very high. So once we assessed the caregiver, the result of the study was perceived stress scale score was low in 18% cases. The PSS score was moderate in next 18 cases, and the highest score was in 14 patients. And the data was also the statistically significant. You can see the predictive value is less than 0.5. That is the p-value is less than 0.32. And the psychological well-being score again divided into in very low group 7 cases observed. In 9 cases low score was there. In 11 cases moderate score, and next 11 cases score was high, and very high score was in 12 cases. Also the psychological well-being score was statistically significant. P-value is less than 0.34. So as per our study, parent should engage in therapies like psychotherapy, relaxation therapy, stress reduction strategies to improve their psychological health. Proper counseling services also assist parents in leading healthy life and maintaining their psychological well-being. So these are the some of my references where I taken my content from this side.
Thank you, Dr. Karan. You took 4 minutes for your presentation. Dr. Kamal sir, do you want to ask anything?
No, madam, it's okay.
Dr. Garg, anyone want to ask?
Just that, ma'am, referencing style is not appropriate. That is what I just wanted to comment on.
So, should we move to another presenter?
Okay. So next presenter is Dr. Aditya Mahindru. Dr. Aditya Mahindru.
Dr. Aditya, are you available?
No, he is not connected. So we'll move on to next presenter, Dr. Surnit Oza.
Dr. Sumit?
Surnit Oza.
Dr. Oza?
And they have not joined, 2 of them. We can start with Dr. Jagriti Yadav.
Yes. So next presenter is Dr. Jagruti Yadav.
Good morning, respected chairpersons. I'm sharing my slides. Are my slides visible now?
Okay.
Now is it visible?
Yeah, you can start now.
Okay, starting with my presentation, my topic is the imminent challenge of novel psychoactive substance misuse, an illustration via case report with review of evidence. So starting with the introduction of what are NPS. NPS are not controlled substances by 1961 Single Convention on Narcotic Drugs or 1971 Convention on Psychotropic Substances. Why are we talking about it? Because these are a major public health threat now, and there is frequent hospitalization with severe intoxication with these substances. As of 18th of May 2022, 1,127 substances have been reported worldwide as NPS as compared to 950 substances till December 2019. Globally, as per World Drug Report 2022, 27 million users of amphetamines and prescription stimulants were there. There are certain complexities of NPS monitoring, like it is a fluid category. The NPS substance, they are modified time and again. No rapid detection tool is there with us, and there is self-reported with local street names, so we are not able to detect them. Same goes with India. There is no reported data from local community. In this picture, I just want you to focus on the India, in which 1 to 9 substances are reported as comparison to 1,127 substances worldwide, just 9 substances. So in this case, I would just like to highlight that mifentramin was the NPS with some harmful effects. A 21-year-old unmarried Hindu male professional wrestler with history of ingestion of mifentramin from last 1 year. Initially, he was introduced to mifentramin by his friends, and then it increased it from 1 to 2 ml to 4 to 5 ml per day within 20 days. And there was acute behavioral disturbance when it was increased to 12 ml just before the onset of the competition. So what happened after that? There was acute behavioral disturbance. He drove the bike at a very high speed. There were erroneous ideas, there were grandiose ideas, and he landed up with severe palpitation and sweating in the emergency. So after medical stabilization, he had to be de-escalated with the use of psychotropics. In the same parallel picture, you can see that there are 4 blue bars. These are the geographical spread of NPS. The 4 blue bars, they represent the stimulants only. In discussion part, I would like to highlight that South Asian countries, including India, they are notable departure country for stimulants. And deep web is the preferred mode of making NPS available rather from the shops. The prompt online delivery fuel these marketplaces, and NPS are often reflected as legal highs, bath salts, or research chemicals, because of which the reported misuse is much lower. Implications from my presentation is there is need of reporting of NPS misuse at local level as well as at national level, awareness programs for the vulnerable population, especially for adolescents. There should be special focus on athletes and sports population. A strong legal framework is required to be put into for prescription drug use as well as online distribution. The management protocols for the NPS misuse should be defined in emergency settings. Limitation of this review is that there is lack of individual case report evidence in this presentation, and there is also lack of evidence from the collateral sources like sports regulating bodies like NADA and WADA. These are my references. Thank you.
Dr. Jagrati, you took 3 minutes and 40 seconds for your presentation. So, what do you think? Why this methylphenidramine is commonly misused in athletes?
Ma'am, because it is a prescription drug as well, and the lax dispatching on the chemist level, it is one thing is that, and also the cost is lesser than the other stimulants.
But what effect it gives that people misuse it?
There is a sudden rush or the sudden high of energy which is required for performance enhancement, to which they are misused.
Most of the wrestlers or athletes says that it increases their exercise endurance. And that is the main reason why they misuse it.
Yes.
And what do you think? Do we use this methylphenidramine in our medical practice? Usually by whom and in which condition?
Yes, ma'am. These are used in anesthesia and as during spinal anesthesia to upregulate the BP and if there is hypotension. However, it is banned in certain countries.
Dr. Kamal sir, do you want to ask?
Okay. No.
So should we move to another presenter? Dr. Garg sir, do you want to?
What is, in continuity with Dr. Swati Joshi ma'am's question, what is Adonis complex?
Sorry, sir, I am not.
You'll get the answer then subsequently. And then you can include in this paper. Thank you.
Thank you, sir.
Thank you, Dr. Jagrati. So now we'll move to another presenter.
Yes. So next presenter is Dr. Sanjay Kalasaria. Dr. Sanjay Kalasaria.
Dr. Jagrati, please stop. Yes.
So he has also not joined.
Dr. Sanjay, okay. So who is next?
Sanjay was the last.
So 3 people are not.
So Surni, Dr. Aditya and Dr. Sanjay not joined.
Dr. Sanjay has not joined actually.
Okay, Dr. Sumit has also not joined, and Dr. Aditya, he has also not. So total 11 presenters were there. Thank you all the participants for good presentation. Dr. Kamal sir, your comments, please.
Okay, thank you all the participants, and thank you the judges also, so it's taking all the pain in the morning.
And thank you, Dr. Kamal and Dr. Ma'am, Joshi Ma'am. We hijacked some of the questions. I couldn't stop asking.
No, it's okay. It's good. Okay, thank you. I hand over to Swati Ma'am.
Yes. Thank you all the presenters. Now, I think this session is over. And thank you, judges, Dr. Garg and Dr. Aruna.
Thank you. I didn't ask any questions on purpose because you were doing such a good job as chairs, and we would also be running out of time if we also ask questions. Thank you for all the presentations. Well done.
Thank you, madam.
So our next session will start around at 10 o'clock, I think.
Yeah.
Okay. Okay.
So we are in time.
Thank you, Kamal sir.
Yes. Thank you. Bye.
Thank you, Dr. Kamal sir.
Yeah, yes. Good. Thank you.
All the doctors are requested to join Hall A, sir.
Okay.
So we'll have all the sessions at Hall A now.
Okay. Thank you.
Thank you. Thank you, sir.
Yes, sir. Yes, sir. You sorry, you can stop the live from Hall.